in, trying to visualize you all coming in the doors of a beautiful, beautiful venue that we're all at, maybe outside in the sunshine rather than all locked down at home. But yeah, we're expecting a few more people, so we'll just kind of give a few minutes for everyone to get in, and then we'll get started. So just for those of you who just joined us as our lovely attendees, we've got a fantastic panel lineup here, and you should be able to answer ask questions using the chat function. You should be able to send them in, type. If we haven't got a huge number of people, if there's enough people that we can change it into an open meeting, then we'll do that. So you guys can ask some questions directly and really grill them on what they've been up to and what their plans are for the future. So yeah. If anyone wants to raise a hand and tell us that they're new to One HealthTech, please do that. A very special welcome. Having been quite new to One HealthTech myself, I know it can be a little bit intimidating coming into a whole big exciting community, but very, very friendly bunch. I'm happy to attest. Okay, excellent. So I'm just going to start off by giving you guys a little bit of intro into One HealthTech Week. As some of you may have already known, we were supposed to have a lovely big conference in June, bringing together lots of very exciting people. Obviously, that's not happening with everything that's going on. So we've managed to very rapidly in the past couple of weeks pivot a lot of that innovation, a lot of that energy into One HealthTech Week, which is we're now at the kind of midpoint of. Been a great week with lots of people getting involved with online events on Twitter, and sharing what they've been up to during COVID, or just talking about other things altogether to kind of distract us all and give us something else to chat about. So my name is Lisa. I'm co-hosting this event with Catherine, who's going to be chairing our Q&A in a little bit. As we've heard from our speakers, I was a clinical doctor, was working for Public Health England in the digital team until quite recently, and now I've decided to go full-time freelance in the middle of a pandemic, which has been a very exciting new challenge. And Catherine is the director of the Centre for Expertise at NHSX, as well as being one of the co-hub leads in Cambridge. So One HealthTech, for anyone who doesn't know, can see a few people are brand new. It's a global grassroots volunteer-led community. And like I said, I'm very new to it myself, and it can be a little bit intimidating coming into a group of some absolutely incredible individuals, but everyone is just so passionate about health tech and doing things the right way, of improving diversity and inclusion within the field. And we've got, I think, about 14,000 contributors across 10 different hubs. We've got people in Australia, Sweden, Ireland, lots of countries, as well as all over the UK. And so we're all about being a warm, welcoming group that tries to be diverse rather than just chatting about diversity. And so really excited to have such a range of speakers this evening. So like I said, our event tonight is What's Happening. We've got 5 amazing speakers who are going to start chatting to you shortly, telling you a bit about their tech, how they've changed what they've been doing to respond to COVID, and some of the sort of challenges that they've been facing and learnings that we're going to bring into the future. And then we're going to have a Q&A. So if you want to engage on Twitter, you're very welcome to. Please use our hashtag OHTweek, and we're at @one_HealthTech. And we've also got all of our speakers have got their own handles that we'll sort of share with you as we go through. And as I said, please make sure you ask us any questions. If you can't think of any, that's absolutely fine. You can just listen along, but you should be able to put in the chat function. And anyone who's got any issues with that, please drop us a message on Twitter. So I know that everyone is here to have a great chat and have a great time, but just as part of our code of conduct, just letting you know that this is an inclusive space. There's no tolerance of people that are going to be rude, abusive, or harass anyone. And if there's anyone is sort of behaving that way towards you during the event, please do flag it to me and Catherine, and we'll handle that. So yeah, thank you very much. Our first speaker then, I'm so delighted to introduce you to, is Melissa Morris. So Melissa is the CEO and founder of Lantim. So this is a platform that uses AI and machine learning to automate the manual processes involved in organizing staff to fill clinical rotas. As someone who has worked clinically, I just cannot stress enough how important this kind of technology is. It's always the bane of everyone's job. And yeah, she is previously worked at McKinsey & Co, and then she was working with them on system change for the NHS, and then was working in NHS London Strategy Directorate, where she came up with this fantastic idea that she'll tell us more about.
Thank you, Lisa. Hi, everyone. I'm Melissa Morris, and yes, CEO and founder of Lantum. So Lantum is a workforce management platform that operates across primary care and secondary care, community care. We've been around for a while. So founded in 2012 and first got our first customer in 2013. And so we've got a kind of quite a broad gambit of clients, and we actually launched in the US last year as well, where we identified basically that all the problems that we have in the UK around workforce management and being short-staffed, exactly the same in the US, and in fact in many ways the US is actually more backwards than we are. So I'm sure some people that might be a bit of a relief to hear. But yeah, so I guess just a quick one about how COVID's affected us. So when lockdown first happened, we actually paused the work we were doing in the US so that we could focus on the UK. Our whole team is UK based, so we thought it made sense to do that. And we actually started working with NHS England to co-design with them a primary care workforce deployment platform. So essentially it was really just enhancing the features that Lantum already had, but really making them a bit more COVID specific. So allowing GP practices to post COVID shifts where they could be really clear with clinicians about whether those clinicians were going to be needed to actually see COVID patients, and if they had enough PPE, and just to give just more explanation and more give GPs more clarity around what kind of clinicians what kind of patients they would be expected to see. So we did that work. We also built a suite of dashboards for CCGs so that they could see which practices had the greatest need with regard to COVID, and also allowing more of a sort of command and control model where actually clinicians could be proactively moved from settings where maybe they were less in demand into places where they were in more demand. So for example, GP practices closing down and 111 suddenly increasing volumes by like 1,000%. And so they really needed a way to quickly reallocate clinicians. And so, yeah, so that's really what we've been working on. And then in the last week, our US hospital that we're working with came back and said they actually wanted to recommence the work we've been doing. So now we've been really working around the clock. So doing all the stuff in the UK and then, picking up on all of our US work around like 6 p.m. every day and then working through the night. So it's been a tremendous strain on resources, but I'm sure the other panelists share my sentiment that having a purpose and a mission during a time like this, actually you're surprised with how much you can actually get done, and I think everybody on our team particularly is just incredibly grateful that they're really busy and that they feel like they're doing something to help. So it's been challenging, but it's definitely been full of purpose. So
excellent. Thank you so much, Melissa, for that insight into what you've been up to. It sounds like you've been incredibly busy. The next person we're going to get speaking is Ash, who's the founder of Medishout. Ash is an orthopedic surgeon working at Imperial College London, founded Medishout after witnessing hospital infrastructure and logistical problems getting in the way of delivering best patient care, such as cancelling operations due to a broken light bulb or having an anaesthetized patient waiting while he's fixing a faulty printer. I appreciate this maybe sounds mad to anyone who's not worked in hospital, but I've got about 20 of those stories myself. So again, absolutely fantastic innovation. Medishout tries to solve these problems, having a digital platform to integrate these logistical departments. So clinicians have an app that they can report any issue while using AI to try and predict these problems in the future before they actually happen. So I'm going to let Ash, sorry, I'm trying to share my screen with you. Let's see. Excellent. Okay, so I'm going to take you through these slides. Perfect. It's just another little plug for our ROHT week and our hashtag. Excellent. Okay, so Ash, tell us all about Medishout.
Brilliant. Thank you, Lisa. We can probably go straight to the second slide. Thanks for the introduction. Great to meet everyone here today. As you rightly said, I'm an orthopedic surgeon by background. I've been working in the NHS for 10 years, and really I started Medishout for exactly the reasons you said, getting completely frustrated at logistical problems stopping me from doing my work. And lots of clinicians will be listening in who will, these stories will resonate with them when you didn't have the right stock or equipment or estates and facilities issues. what I'll do today is I'll just very quickly give an overview of MediShout and how we solved the problem, then talk about how we've been helping during COVID, how we've pivoted, and at the end, just some of the challenges I think are going to be coming ahead in the digital health space. So in the first instance, how we actually solve the problem. There's three ways really. First of all, we have the MediShout app, which allows staff to report any logistical issue they come across. So we're actually the world's first platform in healthcare, which allows you to do that. So if it's estates, facilities, stock, housekeeping, IT, whatever the issue is, you can report it, you can add a photo and get feedback. The second thing we do is using our data, we show hospitals which are the key blocks in a system that are most impacting patient care, so you can get those resolved first. And finally, using artificial intelligence, we're able to predict when problems happen in advance, such as when your medical equipment might break. We have great industry support on the NHS Innovation Accelerator, Professor Tony Young's Clinical Entrepreneur Program, Tech Hub and Google Startups Accelerator. So on the next slide, I will just talk a little bit about how did we help during COVID? Well, actually, we adapted our platform so that we can be taken up by GPs and care homes as well. And in addition to all the logistical problems you could report before, you can now report on things such as PPE or workflow issues. Those problems could be resolved locally by managers' help desks, but also we have started to route that data to suppliers directly, so they can now give you the things to your hospital that you need. And what was really key in all of this is that data aggregation, because by collecting that data in real time, we can really drive transformational change. So, trusts like Imperial College were using us, and some of the really key things that came out of this whole period of using MediShout during COVID was it reinforced the fact that if you give staff a voice, you can pick up on so much important information of what's going wrong in your organization. Secondly, coronavirus meant that we had to change the way that hospitals function, and that was changing on an hourly basis. Now, by monitoring what was happening on the front line, you can then respond. One small example was, one day people went to work and the A&E was divided into a green zone and a red zone. And red zone was coronavirus patients, and therefore, if you're in a green zone, you can't go over. But what we found was patients in the green zone were given no PPE, which is in theory fair enough because you're not seeing COVID patients. But green zone were also triaging, which meant the person at the front was seeing all patients, COVID and non-COVID. So when those reports came through the app, the managers were able to really quickly respond. They updated their PPE policies. We couldn't magic PPE out of thin air, but what we could do is better allocate the resources that the trusts could have, and really gave operational overview to the people who were managing the whole crisis. On the next slide, we can talk a little bit about internally as a company, how did we pivot? And I could probably do a whole presentation on this alone, but three key things was our business model. So we made the call to give this for free to the NHS. In terms of our technology, we had been working with some really great third-party developers who'd been maintaining our platform, but we then brought everything in-house, which was really important because the situation was changing so quickly. As a startup, you have to change on a daily basis. We brought in a head of product called Ali Bassoon. He had just been working as head of product at Touch Surgery, who some people know sold to Medtronic for in the region of 250 to 300 million pounds. I'm not sure, Ali hasn't told me, and maybe he doesn't know either. But that was a real coup for us. And then finally, the team. You have to be able to have a team if you're going to be able to expand and grow and really tackle the problems head on. So we've employed at least another 7 people in the last month alone, which for a company of our size is pretty massive. Just the last thing I wanted to touch upon in the last slide here were, well, what are the challenges that I think are going to be coming as a result of coronavirus solutions? And again, I've just kept it to 3 headline things, but there's plenty more that we could discuss. But first of all, bandwidth. Hospital bandwidth is tight at the best of times. We now have had COVID and we have a backlog. So how are innovations and digital health going to really help in this situation? And my first solution, I think, if we could just click on the button there, would be collaborations. And I think really focused collaborations is key. As an example, myself and some of the other NIA fellows got together and we looked at endoscopy, and there's a massive backlog of endoscopy issues. And we mapped it and figured out we can help at different stages. So my pre-op can help by doing pre-op assessments in the community. Locums Nest can help, find endoscopists or nurse specialists, and we can help bring together the suppliers of scopes, and we can help make things more efficient. So if you're doing extra lists, you have all the equipment that you need. And I think that's really key. Digital adoption, always been quite difficult in the NHS. I think that we should have innovation mandated. I think there should be more funding locally for trusted CCGs, or maybe a percentage of budget has to be spent on this. A really good model is if people look at Mid and South Essex, they have someone called Charlotte Williams who heads up innovation. She has a great team, really good links with AHSNs, and it means that you've got a front door and someone who's overlooking all the innovation in that region, and it just works really well. And then finally, competition, command and control has meant that a lot of technology has been parachuted from the top downwards for some big companies. Initially as a startup, that was quite scary for me, but actually what the last 6 weeks has shown me is that big companies are amazing at doing great things, but startups have a really key role. We understand the NHS really well. We're from the grassroots up generally, we're able to be nimble and pivot. So I think now, if it's possible to have partnerships between big companies who can scale, smaller startups who understand problems and have niche technology, that could really bring some fantastic solutions to the system. And that's the end of my presentation. Be happy to take any calls here or online after today's event, and thanks for having me.
No, thank you, Ash. That was fantastic, and it was really, really great to hear some of your vision, your thinking for the future, and I'm sure we can pick up on that again in our Q&A. So our next speaker, I'm absolutely delighted that we have Richard Andrews joining us from Healios, who deliver Think Ninja. Richard is brand new to One HealthTech, and very kindly, as I was reaching out, got in touch and is absolutely just thrown himself into getting involved this evening. So thank you so much, Richard, for that energy. Richard himself is the CEO and founder of Healios. Having experienced firsthand the challenge of watching other people trying to access support for mental health, he founded Healios as a way to pioneer the world's first digitalization of an NHS mental health trust outpatient services. So covering multiple complex specialist assessment and intervention areas, and blending technology, design, and clinical expertise to give a real personal human connection. So Healios's vision is to transform the experience of how care is accessed and received to help patients and families. So really, really excited to hear, Richard, if you want to let us know what you've been up to with Think Ninja.
Thanks, Lisa, for that kind introduction. And it's a pleasure to be part of the session tonight. So great to meet everyone virtually. So we're talking about mental health. And of course, with COVID, well, of course, we've got the physical threat of the virus itself. Thousands and millions and hundreds of millions of people are, of course, challenged right now with how do they cope mentally and maintain good well-being during this pandemic. So, and that's where Healios sits front and center there to help support young people and adults with their mental health and emotional well-being. And to date, we've been delivering to about 50% of mental health trusts in this country a whole array of mental health solutions to support areas like anxiety and depression with assessments, diagnosis, and treatment, all through technology, through to very complex areas such as autism and ADHD, where we provide assessments as well as post-diagnostic intervention support. So we bring this huge array of digital mental health, psychological solutions to the NHS and deliver care on their behalf. But today is about one of our other solutions that we have, which is called Think Ninja. And Think Ninja was one of our exciting responses to COVID, where we decided to open up Think Ninja for the whole country to use for children and young people during this time. And that's what I'm going to share with you over the next couple of minutes. So if we can move to the next slide. So Think Ninja, in essence, is a coach in your pocket. And we developed Think Ninja just over a year ago to support children and young people between the ages of 10 years old and 18 years of age, to support with their general mental health and emotional well-being, but also if they had symptoms of anxiety or symptoms of low moods, that we wanted a solution that could also support a young person through those challenging times without necessarily the need of actually connecting with a real clinician. So Think Ninja, in essence, is taking the mind of a clinician and sticking it into an app and wrapping it up with various exciting technology. And we can see that on the next slide, that Think Ninja combines this really great design with interactive content, primarily based on cognitive behavioral therapy, which is a well-established, hugely evidence-based psychological treatment for anxiety and depression. So it's got this foundational element of cognitive behavioral therapy as part of Think Ninja. And then we have these other kind of important elements around gamification and other interactive experiences that a young person has when they engage with Think Ninja. So it's all about mental health, maintaining good mental health, and then supporting a young person if they have symptoms of anxiety or depression. If we move to the next slide. And so when you engage with Think Ninja, you actually have a virtual dialogue with a wise ninja. So we wanted to create an experience where a young person can have like a conversation with the equivalent of a clinician through a virtual avatar that we call the wise ninja. So you have this great dialogue as a user, and then the wise ninja takes you to these really interactive screens where we take design to that next level. So a young person can learn more about, in this example here, physical symptoms related to anxiety or low mood, and be able to kind of challenge themselves in some of those unhelpful thoughts they may have, or safety behaviors that are causing the continuation of their symptoms. So that's the background on Think Ninja. And we decided then to, with the next slide, we decided to ensure that Think Ninja is really widely available as much as possible to support COVID. So pre-COVID, Think Ninja was commissioned by NHS organizations as well as schools to support children, young people with their mental health. And so it was a commissioned product, but we decided that for COVID, we wanted to make it freely available for any 10 to 18-year-old across the country. But not only that, we wanted to make it very focused as well on the particular need around COVID. So with our great kind of clinical in-house team that we have at Healios, and of course with all our expertise of delivering various psychological services to the NHS within children and young people services, we developed some fresh content for Think Ninja around COVID itself. So that covers things around what is the virus, what does isolation mean, how do I cope in isolation, particularly if you're isolated with perhaps family members you don't get on with, and that of course challenges our mental health, through to if you have general kind of worries about your own health or worries about family members getting the virus and so on. So many of these challenges that young people have with living in this very unique situation, and to make sure that we really do support them with that. So we quickly, with our great team, developed a very extensive kind of COVID resource within Think Ninja, all done within a week. It was just a massive kind of Herculean effort by the team. And then we wanted to support the awareness of Think Ninja. So we partnered with some national children's mental health charities, for example, Place to Be and The Mix, which are two great national charities, really just to help raise that awareness of Think Ninja so we can get into as many young people's hands as possible during COVID. And as part of that, we're also kind of in discussions right now, they're ongoing, we're hopefully to bring that to a close fairly soon with NHS England and NHSX to get their support with and backing of Think Ninja during this COVID crisis. So we did lots of kind of important steps as a company to get Think Ninja into many young lives' hands as possible. And on the next slide is our learnings from this. And of course, when you move at speed, and my fellow kind of health entrepreneurs here can kind of relate to this, is that as a kind of a startup company, early stage company, we do move quickly. But in a COVID situation, of course, we have to move even faster. And one of the things we're very used to is making sure that we are able to still make quick decisions. So one of our learnings during COVID is the importance of still having the courage to make decisions quickly. Many of those, they have a large degree of risk associated to them. We don't know if they're going to work. We're going to have some failure around some of those. But it's just that confidence and courage to make these decisions, knowing that you're doing the right thing in these environments. So that was certainly one of our learnings, is that courage was really important during this time. The other important learning we had actually when we kind of decided to take on this kind of national launch of Think Ninja is that it's still very much about people. And particularly as Melissa was nicely mentioning as well earlier, that when you have a massive transformative purpose, which we often do in healthcare, about improving lives, reducing morbidity and mortality, whatever that is, our teams get behind that. And we're constantly getting them involved in that and believing in that. And that's driving passion, energy, and so on. And then COVID sits on top of that. So you're asking teams to go even further behind a massive transformative purpose really quickly. And then you have to deal with the outside world, who often aren't moving at your same pace. And so still very much our learnings is how people and relationships, interactions are so key, even responding at even greater pace in the COVID environment. And then maintaining momentum, we felt was a really key learning during this. It's not just about how you respond to COVID in the first step, but it's about how you continue maintaining that momentum, keep pushing until you achieve what you set out to achieve, which hopefully ties to your core values as a company. In this case, Think Ninja clearly did. So that was our learnings from COVID. So thanks everyone, and hopefully that was useful.
Oh, that was fantastic, Richard. Thank you so much for taking us through that journey. And I'm so glad that Think Ninja is so widely available to all young people in the UK. And I really encourage everyone who's here listening in to share that with your networks, young people you know that you work with, and spread the word. Such a great resource. Excellent. Well, I'm going to stop sharing now, and I'm going to hand over to Chris, who is a former NHS doctor turned entrepreneur and is now the CEO and founder of QDoctor, which she's going to tell us all about.
Thanks, Lisa. That's great. And like everyone said, thanks very much for having me. Apologies for the least professional background on the whole panel with the nursery balloons behind me. So just to give you a brief kind of background as to what we do at QDoctor, my background, as you said, Lisa, in the NHS as a doctor, it started for me 4 and a bit years ago, starting to meet clinicians who were talking about online consultation, but were mainly kind of worried about whether the NHS might start to fall behind as that developed, and that the private sector kind of caught up faster than the NHS. So that's where it came from. I approached NHS England and actually joined the same program that Ash on the panel is on as well, a clinical entrepreneur program. Started to get as many clinicians as we could to build something that was going to be kind of focused on the NHS and to support it with online consultations. We very quickly realized we had something of a workforce solution, because as we built a video consulting platform and some tools around it, we had a lot more GPs join us as a group. And obviously parts of the country just can't get the GPs that they need. So this kind of quickly became obvious that we needed to start delivering them, and we do something called a digital locum service. We also started working in pharmacies at the time, although that moved from initially a private model to an NHS funded one. The trend that kind of in the following kind of year and a half was towards actually lots of GPs out in their practices. We're seeing this being done and delivered as a workforce solution, and realizing they themselves could be delivering that, and it could help them do evenings and weekends if they used our software. So we had a lot of momentum build up over the course of about a year and a half, 2 years. Last year, we were kind of middle of the year, we had about 300 practices under contract. I'm kind of sticking to the pre-COVID stuff first. We expanded out beyond GP, so very quickly moved into 111 and urgent care. So last year became, beginning of last year, became the first video platform through an approval process for 111, which, as you can imagine, is a really, really busy part of the business now. Just because of some key kind of metrics and evidences that came out of some early work there. And also in outpatients, where there's been, as of fairly recently, a national drive towards digitizing that, and we customized our platform for use in those other areas. Urgent care really got big very quickly. We work with some of the largest providers of urgent care around the country now. And as you can imagine, as a broad theme of this, obviously COVID has really pushed forward digital transformation across all of those sectors that we're in. Particularly general practice has moved very quickly. Some of the effects of COVID for us, so we were lucky enough to be on, we're on 2 kind of COVID-19 national frameworks. So there are 2 routes that anyone across primary care can, as an NHS organisation, can take on our platform free of charge, and it's centrally funded. So that's been a really kind of key enabler to be on those approved lists of video consultation supply. As you might expect, big increase in usage across the board for us, and echo all the sentiments that the other panelists have said already, which is around having the message for the team, and there's a big ask and a Herculean effort that goes towards kind of scaling so fast. We've onboarded over 1,000 clinicians in the last month, and all of our graphs are very exponential, as you might imagine, in the sector. We've seen some utility of what we've spent the last 2 years building, so particularly around insights into what happens when you bring stuff online. We've worked, so we were lucky enough about 1.5 years ago to be commissioned across a whole STP, and we worked in partnership to build insights dashboards into what's going on as they brought their community clinics and their practices onto our platform. They wanted to know how is that benefiting them. Clearly we had that built before COVID came along, and some of the work we've done very recently has been about adapting dashboards to give COVID data and to say, well, where are the hotspots, what's happening in real time across all of these sites that we're starting to digitize, but now have very quickly digitized. So that's been really good to kind of use the stuff that we've been taking the last year and a half to build. The other thing was, I guess, in a way similar to what Melissa was saying with Lantum. So reallocation of that clinical resource becomes a lot easier when it's in an online status. We've had some adaptations of our platform where parts of different areas of the country have just needed to do that, needed to reschedule. And being able to do that when you're working remotely is obviously can be plugged in, those clinicians can be plugged into different parts. And the final bit was actually related to the original digital locum delivery that we started off with, and we still do a lot of, because to get clinicians working remotely for different practices actually has a lot of benefit for clinicians who are suddenly self-isolating because of COVID-19 in terms of the technology. So we had what's called virtual PCs that sit on people's own devices on their laptops, connected into the NHS network and allowing them to securely access clinical systems and the NHS network without the need for a dedicated laptop and a dedicated smart card reader. So we had that already, and suddenly when COVID came along, it was like, well, we've kind of built that already, and we can start offering it on its own, because all of these NHS organisations have got clinicians who are well, who are having to stay at home. We have a virtual PC that they can spin up very quickly. So that's been another area of growth in our business, and it's been really nice to have that solution sort of ready and readily available. We've got several hundred of those clinicians plugging in, and again, it's a very exponential curve in terms of daily the number of new people joining and using that technology. So yeah, overall, that just a quick background of what we do, but really exciting to be supporting the effort towards dealing with COVID.
Should remember to unmute myself before I start speaking. Yeah, that was absolutely fascinating, Chris. So it's really interesting to hear how you've managed to do that. And we're getting lots of love in through your background as well. So absolutely no worries. Our last speaker that I'm absolutely delighted to introduce before we get into our Q&A is Alina, who's the founder and CEO of Fibris. She's a biomedical and AI engineer with a PhD in machine learning for healthcare innovation, which I did not know was a thing, and it sounds absolutely incredible, from Oxford. And she, like I said, is the co-founder of Fibris, a company whose AI-powered platform enables carers and community health workers to detect conditions early, which, as I'm sure you'll all be aware, is an exceptionally important thing to be able to do in the middle of a global pandemic. So yeah, Alina, if you want to talk us through what you've been up to.
Thanks, Lisa. It's an absolute pleasure to be on this panel today. I think I got a bit jealous of Chris's background and created my own, so I'm trying to replicate the clouds digitally. So yeah, as Lisa is saying, we've built an AI-powered platform for community health, which enables non-medics to capture high-quality medical information and then subsequently speed up the access to diagnosis and treatment. And we actually got into this space years ago from a global health lens. So we were obsessed with solving a very specific problem called childhood pneumonia, which annually kills nearly 1 million children. And we thought that was absolutely absurd, that in the 21st century, a perfectly treatable disease would take the lives of so many kids. And really our goal was to figure out how do we leverage the power of kind of advanced technology like AI, which we've seen transform hospital workflows, and push it into community settings where a lot of workers, particularly community healthcare workers in global health, just don't have the tools to detect these complex conditions. So originally we built up a platform which was focused on that specific workforce, and connected medical sensors like digital stethoscope, pulse oximeter, thermometer, so that we can fully automate the data capture as well as some of the initial triaging that they can do for very small children. So that work scaled, and we've been running a program for about 10,000 children in India. And last year we also got into elderly healthcare in the UK specifically, where our focus has been carers and enabling them to detect community or ambulatory care sensitive conditions in the community, which often lead to avoidable hospitalizations because they're not picked up early enough. And I guess that work was going great, but then COVID hit, and two things happened. I guess that massively accelerated the need for what we do, but also introduced a lot of additional learnings, particularly as we started working more in care homes. So a few weeks ago, we actually won TechForce 19, which is an NHSX competition for innovation, particularly in the context of COVID, and have been working with various care homes in East London, about 20 of them, trying to really fully digitally deploy innovation into these really challenging settings. And some of the things that we've learned in that process have been the need for very smooth onboarding, particularly in these very stressful environments at the moment. Like anything that introduces additional stress is really not a good idea. So whilst originally we had a kind of a train the trainer approach, where in an organization we'll try to train up a super user and then they'll distribute innovation around them. Here we've had to fully digitize and automate the onboarding through videos, so that it's as smooth as possible for every carer that picks up the technology in the care or nursing home where they work. Another big learning for us has been that healthcare systems have changed in a way that's made them look more similar than ever before. So features that we've developed for our India deployments in urban slums, for example, that we thought were kind of only for that setting, became really relevant. So for example, all of our checkups can be entirely offline, because in an urban slum, you don't have the privilege of having constant internet connection. But apparently neither do you in a care home, in a lot of London care homes. So that's been quite a kind of a blessing in disguise, I guess, that we already had that developed for a completely different setting, and we were able to use that in care homes. And also loads of learnings around how the workflow is now evolving and changing around these users, particularly around task shifting, transforming kind of the role that clinicians play, the need to fully digitize the patient journey. Like all of that is happening at the same time, which introduces tremendous pressure on the people that now have to operationalize tasks that were typically associated with doctors. So I guess one of the big takeaways, and something that we continue to kind of learn from and struggle with and figure out how we do moving forward, is as a technology provider, where does our role stop in change management in these environments, particularly as we are expecting carers to pick up technology that now feeds into a completely new care pathway. So I guess that's an ongoing learning and exploration for us, but I'm guessing for everyone else as well, including the NHS. So I guess final thing to say is, just like everyone else on the panel, we're tremendously privileged to be able to work with users that are making tremendous change, creating tremendous change at the moment. And we hope that we're making a difference, or helping at least a little bit to ease some of the difficulties that they're facing.
Wow, that was so interesting, Lena, and what a great question and thought to leave us all with as well. And thank you so much to everyone, the panelists who've come to speak today. And I genuinely do think all of you are doing fantastic things across the health service, across the COVID response. So I'm going to let Catherine take over now to moderate our Q&A. We've had a couple of questions come in already. But yeah, Catherine, over to you.
Brilliant. Thank you, everyone. That was fantastic. And for those of you who didn't manage to get the introductions, hi, I'm Catherine. I work at NHSX and I am the Cambridge Hub curator for One HealthTech. So we've had a couple of questions come in. I've written down a bunch that I want to ask you guys. So I'm going to ask the one from the audience first, but if everyone who's in our audience can put their thinking hats on, and start to think about what their questions are. I'll come to you in a second. So the first set of questions we did have from the audience are about basically the economics of giving stuff away for free. Now, I think the NHS has been overwhelmed with the generosity of big and small, but how, I mean, probably specifically thinking, I mean, Ash and Richard, you both mentioned making your services available for free during the crisis. How have you made that work, both in terms of from your business side, and how do you think that's going to impact your business model going forward? And I'm going to sort out my video. Ash, do you want to kick off first? Then I'll come to you, Richard, on that one.
Yeah. I think it's a really good question and something which can be debated in lots of different ways. Our personal view was, okay, like the freemium model, it's not like it's suddenly been invented during COVID. Last year I was using Uber all the time and suddenly 4 or 5 other competitive apps came on offering their platform free. And when that ended, you end up saying, well, what's the best of all the competitors out there? I think it's really important to also think about how long do you give it for free and what are your options? We looked at this and thought about it. And we said in a perfect system, you'd have unlimited resources and unlimited solutions and you'd just buy the right thing at the right time and it would happen smoothly, but that doesn't really happen. So you can either give it away for free and just help the system get over the hump. And then if you're showing value, people will pay for that down the line. And if you're not showing value and no one's using your product and it's a hindrance, no one's going to pay for it. Or if you're able to charge at the time and you can, provide value and get paid at that time, then that's great as well. I don't think there's a right way or a wrong way of doing things. For us personally, we were quite lucky in the way we've always structured the company to be really lean. So, try to avoid having really high overheads. I've spent 8 years, building the technology around the needs of the NHS, for example, so that we don't have to spend loads of technology to pivot and adapt. The platform was already kind of able to do that. We just had to make some tweaks. I think that's really important. So we'd almost built our company for a rainy day. So, we haven't been hit as hard as we might have been during COVID. Richard, I don't know what your thoughts are on this.
Yeah, thanks, actually. So from our side, Think Ninja is just one of many digital solutions that we bring to the NHS and other stakeholders. So, I mean, we simply just looked at our values as an organization, and our values, one of our key values as an organization is doing the right thing, for our staff, but also for our main user base, which is people challenged by mental health conditions or autism or ADHD. And so we kind of really hold ourselves strongly to our values. So when COVID sort of emerged, our quickest way to make the biggest impact with our assets that we had is with Think Ninja, because we knew that was just instantly scalable. We knew that we can just roll it out super quickly. And we just weren't thinking about a commercial model around it during COVID at all. We just thought we just have this asset, let's just make it available so that young people can benefit, because we know that young people during COVID are of the most vulnerable group in our society during this. And we do focus as a company, our strategy is around children and young people. So it just felt the right thing to do. What happens post-COVID? No idea. I mean, if that does help us maintain Think Ninja broadly around the UK with some commercial arrangements. That's just an upside from our standpoint for now. So we'll get to that, I think, post COVID. But for now, it was very much short-term focus. Do the right thing.
Brilliant. Thank you both. I think that's showing the level of pragmatism that is very refreshing when dealing with entrepreneurs. So bad news is I can't get my video to start, but I'm just gonna keep going and apologize for that. I know it is not best practice video consultation etiquette, but the next question we had from the plenary is, again, it's another one for Richard, but it's also one for you, Eleanor. Is, do you consider yourself to be medical devices? And in which case, do you want to talk a bit more about your, probably, I'm guessing, slightly difficult and troubled journey around getting regulated? I don't know, maybe you'll have a good news story about that. Eleanor, do you want to kick off on that one?
Yeah, sure. The short answer is yes, absolutely. We actually have quite a strong stance on this, that there are too many solutions that should be considered medical devices and aren't. In our case, we are going on our own kind of personal journey as a company with the aspirations to kind of graduate through the different levels of regulation to reach a status of a fully diagnostic device, or software as a medical device, if you wish. Originally, we are a decision support tool, which means we can support users in capturing data, moving data, standardizing that flow and process. What we can't yet do is conclusively diagnose people through the software. So that's kind of the end goal that we're hoping to move to over the next couple of years. In terms of process and happy stories or sad stories on that front, I guess the main kind of learning we've had is that that's one of the parts of AI related innovation that's as kind of novel and as evolving as the innovation itself. So the regulatory landscape is maturing, but at the end of the day was developed for hardware and the things that used to go through the process, CT machines and X-rays or stethoscopes. It's very new to have software, and particularly AI, go through these really rigorous processes. And it has massive implications in terms of speed of delivery and so on. So loads of kind of small and big learnings. If anyone is specifically interested in what that looks like, very happy to share those offline. But I think the main takeaway for us has been really learning with the regulator and figuring out what that process is likely to look like in the future, and trying to be as agile as possible as we evolve the technology. Brilliant, thanks. I mean, I think there's things that we need to do nationally. I know that, you know, NHSX is not in charge of medtech regulation, but if we can you know, be of influence in helping smooth that, I think that's going to be something important that we can help with going forward. Richard, is there anything else you want to kind of add from your perspective? I mean, your kind of the support you offer young people is slightly different to Eleanor's, but I'm sure you've probably had to go through at least some of that part of that process.
Absolutely, yes. We've evaluated our digital solutions that we have on whether they fit under a medical device classification. So the core of our business, which is where we deliver clinician-led mental health and autism and ADHD services through technology, that does not require a medical device for a variety of reasons. We don't need to go down a class 2A or 2B for that. I think Ninja is slightly separate, and it's very much about a stepwise development process with Think Ninja. So Think Ninja as itself today as an app is about an educational tool about mental health and emotional well-being, and a skill building tool to give you skills to help in your day-to-day lives. So in that sort of classification, it's not required to be a medical device, and it's designed to sit alongside as well other kind of medical care or psychological care that someone may have. But we do have a development program to take a version of Think Ninja into a medical device, so that we can then say that Think Ninja can treat, can improve, and so on, certain mental health conditions. And that's a development program that will take a version of Think Ninja forward towards a medical device.
Brilliant. I think that's really, really helpful. So the next question is actually one that I'd written down, but also one that someone in our audience has asked, and that's about social care. Now, at the moment, social care is probably where the brunt of the virus is being felt at the moment. The question we've had from our audience is about how we might approach the lack of data that we in social care, both around mortality rates, but also perhaps around what staffing is needed, and where staffing is like short, like temporary staffing might be available, where PPE there are shortages. I know that a number of you have thought about how you can support the care sector, but I'm going to start with Chris, and then I'll go around each of you. But if you kind of could just think about what you would do if you could help social care, and in particular, I guess pick out the data aspect that we've been asked.
Great, sure. I think so. Our platform's been used a lot in the last few weeks for linking up care homes to practices, which it hadn't before. So that's been a kind of a brand new use case for it, and it was just kind of, as I said in some of the other aspects, repurposing the same platform. I guess the data bit, it's fed into the dashboards that we were building. So showing that activity for not just obviously the practice knows what consultations just happened and what the general outcomes were, but being able to feed that in real time to a slightly higher level, and in some cases more kind of command and control level, for a CCG or an STP, to have the health aspect of the view of social care is kind of where we've started to see that activity rising. Love to do more if there's a way that we can repurpose that further. It's very flexible in kind of the bits of data that can be picked up. I think there are some use cases that aren't so clinical, that aren't necessarily the GP, but actually you can link up carers to the people that they need to speak to by video. So I'd be very keen to kind of explore how that might work.
Brilliant, thanks, Chris. Melissa, what would your reflections be on how Lantern could support social care?
Yeah, actually, quite, because Chris and I are in quite a similar space, but Chris more on the like telehealth side, and we're more on the kind of workforce management. But yeah, we've had a number of so we can see how people are using the platform, and they're using it for different use cases. So a lot of GP practices are posting shifts for GPs to go and visit shielded patients. So previously, you know, they would post shifts and GPs would just come into the practice and see patients, but now much more kind of going to see shielded patients and going to care homes as well. But I think, yeah, like kind of not with my Lantern hat on, but just with my like, what wouldn't it be great if kind of hat. I think if you could have widespread adoption of remote patient monitoring, I really think that would just be the biggest game changer, like in terms of the data you collect, in terms of like how do you prioritize the resource and where should it go, who's in greatest need, and spot, you know, various patterns. I really think if that was, I mean, there are companies, this is the one thing I'm sure everyone feels the same about this when it comes to the NHS, that, you know, these problems that we have, they've been solved by many tech companies, but it's about how do you get widespread adoption. You know, it's like MeadowPad does great remote patient monitoring. We've recently seen some of our practices that we work with have adopted it, but like I've never seen it being adopted in primary care before. And even still, it's kind of only, you know, the odd practice. But, you know, how can the NHS really support widespread adoption, and what really is the barrier to really ensuring that, you know, you really can push forward? Because I think the NHS, the response to COVID there have been some quite big, you know, heroic projects that have been kind of lifted, but I would say on the whole, it's been a low tech it's been quite low tech, I think, compared to what we've seen in other countries. And so how, like, what actually are the barriers to widespread adoption? Because yeah, I think we're not short of innovations, but I think we are just kind of short of the kind of how do we get it out there.
Brilliant. Thank you, Melissa. I'm going to actually go straight to Eleanor, since Melissa was so passionate about remote monitoring. I mean, so beyond what kind of you're doing in the respiratory space, like, which is, and you're obviously already working with care homes, you know, what would, if you could kind of slightly wave your magic wand in terms of like the work with the care sector, what would you do?
I'm gonna not trivializing this. I'm gonna go for listen. I think the biggest problem, and kind of building on what Melissa is saying, the biggest problem with adoption, particularly in community settings and care homes, is we're trying to repurpose things that were built for hospitals and push them onto users that are not hospital doctors, that are not GPs. I think that's been a barrier that's actually been the same challenge in global health, where we develop something very useful in, let's say, the UK, and then try to force users elsewhere to use it. And unfortunately, users in different settings have very different needs. So my wish for the care home setting and anyone innovating in that space is to listen more closely to the users they're working with, and to be more agile and evolve their solutions around all the kind of challenges that this workforce is facing at the moment. So just to give you a very practical example, on some of the regular calls we do with users last week, where we kind of allow them to make any feature request that would transform their day-to-day. They were asking if we could use our remote monitoring platform for doctors to verify that someone has actually passed away, which is not something a health innovator would naturally come up with. We think there are gadgets that are gonna, you know, diagnose a disease and save lives, but sometimes there are things that care homes need that don't typically feature in our kind of product roadmaps. So yeah, that's my big learning on that front.
Brilliant, thank you. And I think that point around listening, and particularly to our users, like, that is, you know, a fundamental truth, and I'm sure one that everyone on the panel would absolutely agree with. So Ash, what are your thoughts on how MediShout could support the care sector?
So we've been speaking to quite a few care homes and people in NHSX about how we can help. Kind of takes me back to something Melissa mentioned about how do you get widespread adoption. So there's lots of innovations which can help. You know, something that I mentioned in my talk earlier this evening is about, I think, you know, bandwidth is an issue. You can help that by people collaborating together. So for example, we've been in discussions with the concept of, okay, so we need to make staff more productive and help staff in order to treat you know, people and patients in care home settings. Now, let's say you use the MediShout app to report your logistics problems and your IT problems, and they get resolved. And then let's say you mention there's a problem with staffing. Maybe that information can then get sent to Melissa's team and they can help with that problem. Or what if you mention that you need specialist advice really urgently, and then Chris's team can come in and provide that. So I think end-to-end solutions of, you know, there's different pieces of the puzzle, and if we try and work to put them together and have end-to-end solutions, that's something that could really help. And that's something where you know, MediShout, we're really keen to do that at the moment, because we think obviously we solve a big problem, but there's lots and lots of big problems. And if everyone's working in isolation, it's just going to overwhelm the system. And, you know, people might think externally, someone like Chris and Melissa are competitors, but they do really different niche things. And I think bringing certain things together could really help social care at the moment.
Brilliant, thanks Ash. And finally, Richard, what would be your kind of reflections? I know you've been focusing specifically on young people. There are obviously a whole cohort of young people who are in kind of social care, but equally perhaps other aspects of the support you would offer would kind of benefit the older population as well.
Yes, so of course, mental health and social care are so intrinsically linked. And I think some of the areas that we feel that we can play a role, as well as other digital mental health companies, is firstly around the those accessing social care have the ability to access quickly mental health services that can support them in their circumstance, whether they're in supported living, etc. So that kind of ability to really support that whole social care environment with early access to assessments and early access to treatment, which is even more important. So there's just such a clear role there for supporting social care on that side, opening up access to mental health services in a as easily and stress-free way as possible. But then it works the other way as well. So a child who or adult who has an autism assessment, that could then lead on to opening up more social care support, for example, or other types of mental health diagnosis may actually then again open up more social care support that's kind of desperately needed, not only for that individual but also for that family around that individual as well. So there's this whole aspect of access and treatment on mental health and how that works both ways in the social care sector.
Brilliant. I think that's a really great point around like the whole person-centered care, and in particular something I've been thinking about a lot at the moment is, with everyone really being at home, is how we need to think about households. And actually, if you've got a shielded person, like that effectively means you've got a shielded household. And how can we focus our interventions on everything that family needs, not just on the shielded person. So the next question is one close to my heart in NHSX, and it's one for Chris and potentially Melissa. Interoperability. Have you, and I'm going to frame this in a kind of COVID way. Has anything happened in the COVID kind of response period that has made interoperability easier? Because I know it's probably like your biggest headache from before.
Yeah, big headache for me. I think probably 90% of our engineer resource goes into it. The swiftest movement that we've seen has been integrations with partners who are also getting their stuff out there at pace, like we are, rather than necessarily the kind of traditional integrations with the bigger clinical systems, which I guess, for me, the jury's still out as to whether that's moving quicker now or not. But where we're kind of ploughing ahead is where we're seeing some really useful integrations with partners. I don't know if that's the same for Melissa.
So I guess, I don't know, actually, Chris, I don't know if, like GP Connect, and allowing for the sharing of patient records, like, I don't know, that to me seems a huge stride forward, but I don't know how that's affected you or if it's helped or hindered you in any way.
So we're going through that. It's kind of, but it still has the process around it. So that's a great kind of product of the last probably 2 years of making more agile the integration processes. We were kind of teeing up to do it as COVID kicked off already. So I'm not sure yet whether it's going to be quicker or not.
So from our perspective, it's slightly less important. Like, it would be a really great nice to have if we could integrate with EMRs, etc. But we don't have to. So people use Lantern to host their schedules, their rotas, and then they can also access our wider marketplace to find additional clinicians who are vetted, who can basically fill in to shifts. So you can use that independently from your other software. We do all the payments, so basically we've done everything ourselves, basically, because there really didn't seem like another option, and it seemed like the legacy systems were very closed for business. Our experience in the US has been really interesting, though. So we went and worked in a US hospital, Cedars-Sinai in Los Angeles, and we hooked into all of their systems like in weeks. And the reason why it was different is the approach. So in the UK, vendors are just asked, talk to that vendor over there and sort it out amongst yourselves. And obviously the large, big legacy vendors who have absolutely zero interest in linking up with small startups just kind of don't answer your emails, or, maybe you can't agree what information standards you both have, or whatever it is. That approach seems to not really work. And in the US, the hospital that we work with, they had a huge IT team that was just dedicated to basically linking up all the systems, and we didn't have to talk to the vendors at all. And we just basically there was a middleware that linked us all in. And we were in there in weeks, and we could basically we were set up on the link to the payroll system, the electronic medical record, and it's just such a different experience from what we've had in the UK, where basically they've kind of really decentralized it and expected us all to just get on with it, and that doesn't seem to work. So I guess from our personal experience, we haven't seen any movements in interoperability that's affected us. I think the GP Connect movement, that is a massive feat, and I really have a lot of respect for the team that were involved in making that happen. But personally, we haven't been particularly affected by it.
Brilliant, thanks both. And I think there's an interesting reflection on how I don't really feel like we've tackled any great strides on the interop space in the last 8 weeks. I feel like there's still a huge amount of work we need to do to kind of work with that. And I think there's an interesting learning about, as you say, Melissa, around whether there's ways to kind of fudge it elegantly. And certainly I know some trusts are using basically robotic process automation solutions to effectively make all of their systems connect, so you kind of fudge the interoperability. Cool. So the next question is a much more kind of strategic one, and there's actually a couple I'm going to ask as a bundle, and I'm going to start with Ash. So what do you think makes an app great, and how has COVID disrupted your kind of strategy, and are you kind of worried or hopeful for the future? And maybe I actually should ask you, what makes your app great? That will probably be a better question, and then I'll go around the others.
No, I'm not here to self-promote, so no, I'll take the original question. What makes an app great? Ironically for me, I mean, what makes an app great is everything that isn't to do with the app. So when we work with a hospital, most of what we do is about understanding systems. How can we improve existing systems and workflows, get everything aligned, and then you just drop the technology on top right at the very end, and then that makes everything seamless. You're changing human behavior, culture. You're trying to get people to work together, different departments, IT, estates, facilities who historically haven't worked together. And I think that's really what makes the app great. If you can get all of those things aligned, then the app or the technology side, in our case anyway, should just talk for itself. In terms of how has COVID disrupted us, I suppose it's speed. So speed is, healthcare is changing on an hourly basis, and that's if you're lucky. Sometimes it's a minute by minute basis. So the second you think that your startup is able to really help, goalposts have shifted, and suddenly you're like, oh, okay, we better be helping with this, or we better be helping with that. And then now we're thinking about, having hospitals, dual hospitals, which are part COVID, part, emergency elective, and then who knows when we get back to, true elective work. So I think that has probably been the biggest disruptor, because you have to be more nimble, think more on your feet, think really creatively. As we said before, how do you build a team when you've decided to give your product out for free for the NHS? You've got to think creatively around these decisions. And then your product as well. You've got to think to yourself, well, what is going to be the thing that helps the system most right now, in the next month, in the next 6 months? And I'm not sure I don't think anyone knows really what the right thing is beyond a month from now. And I think that's probably the biggest disruptor and challenge. But actually, I kind of feel, I feel quite lucky that I'm in a position where I've been working on something for years, which can really help right now, whether it's with PPE or the logistics and productivity of a hospital. So the challenge is great, and the team who've come on board, they love it, because every day we're just faced with something new that we've got to tackle. Sorry, I went on a bit there. There's 2 questions into one.
No, it's great. Richard, your take.
So on the app front, I think from our side, I think it's about does the app continue to deliver value to you as an individual, and as those needs change as an individual, does it continue to deliver value to you? And I think from our standpoint, that's kind of how we think about Think Ninja, is just how does it continue to add value to a young person's life. And then kind of the next level down for us is then just how do you turn that into just an amazing experience? Because if a user as an app gets a great experience, then they're going to keep using that app. So it's very much then about design of that app, user friendliness of that app, and all these many other things that app developers think about to create just an exceptional experience that addresses their need, gives value. So those are kind of things that we think about what that goes into forming a great app. And then from our strategy as a result of COVID, so into Ash, we're in a sort of fortunate position where, of course, with COVID, it hasn't changed the view of mental health. What it has done is actually, sadly, it's making the mental health of our nation a lot worse, and the mental health of nations around the world. So what sadly we are going to see is a much larger demand as we move through COVID and as we exit COVID on the well-being of our society, particularly as we potentially moving into this recession period with job losses, with people struggling how to move forward. It's just going to exacerbate so many mental health challenges in children, young people, and adults. And so if anything, there's going to be much more demand coming through. So our strategy is unchanged. I think there's many great things that are happening there in mental health services in this country and in other countries on how they've adopted digital even more now to support the current environment, and how they keep that momentum going as we exit COVID, kind of that supporting that digital integration into mental health services and designing those that are fit not just for today's society but really for tomorrow's society. And so our strategy is very much still linked to that, and we're fortunate that we don't need to change that.
Brilliant, thank you, Richard. Eleanor, what are your reflections?
So on the app greatness front, without repeating too much, I would say definitely being user-centric. And the only other thing I would add is modularity. I think particularly in healthcare, needs are very variable and also quite challenging. So having the ability to kind of personalize and optimize around the user is quite crucial. On the challenges versus feeling positive for the future, I think we are definitely feeling very positive. I mean, it's absolutely tragic kind of what the pandemic has brought, but at the same time, I think it's removed a lot of barriers in terms of our thinking, because across the board, I think in the digital health space, we're now on the same page. And before, we had to have conversations of whether or not some kind of legacy processes had to continue because we have them in place. We just can't afford to do that anymore. Everything from kind of remote monitoring to the way our kind of referral pathways are structured, all of that has to change to be far more efficient and far more optimized around the challenges that we face today. So that's all very difficult, but we're very hopeful that down the line it would actually mean a massive improvement to the healthcare system that we have.
Brilliant, and I think we can all really get behind that. Chris, I know that you and I have had many conversations around what useful functionality should go in the QDoctor app. Do you want to give your headlines on what you think makes the biggest difference?
Yeah, I think, well, ironically, COVID's kind of enhanced the non-app usage. So I guess that's goes back to slickness and speed. You know, we found that lots of new services and lots of services, NHS services that are scaled up, have wanted just to get people on board very quickly, and that includes the patient users, and they've just wanted to send them a link and get them joined up on video, and then actually just look at when the best moment is in their set of services to look at getting the app pushed and people made more aware of the things that an app can do that in our case, a web browser can't. So that kind of links to the strategy question, really, because there's been an urgency ramp up, and we've had to get, there's a need to connect the people first and foremost, because that's what the core of what the platform does. But then actually the app functionality that we have, there's stuff like it can call people, makes the phone ring, whereas a web browser can't do that. So there's a kind of, that has really big implications depending on which service you're providing video consultations to. So there's kind of been that disruption, I guess, but I think actually that's enhanced the whole market. Everyone is thinking in broader terms about modularity, actually, which is what Alina said, is kind of how do you fit these functions? Like, most people are agreeing that video is a great thing to join people up, but there are different kind of workflows to get people in, and to provide the right features to the right service is a variable beast. So modularity is a really, really key aspect as well.
Great, thank you. And finally, Melissa, anything final you wanted to add on those kind of questions?
I actually don't think so. No, I think everything that I was going to say has already been covered, and so yeah, I didn't have anything to add.
Cool. Then I'm going to ask you to answer the next question first, and this is a kind of story around, or asked you to think back a bit about what it was like and how you went about getting your first NHS customer. And then also, I think at the same time, be really good to know like how conversations with your investors are going at the moment.
So a long time ago, getting our first NHS customer. So we purposefully chose to start in primary care and then graduate to secondary care afterwards. And the reason why is because of the amount of bureaucracy that we could see in secondary care, and we felt like we could raise £1 million as our first seed funding, and we kind of looked at how long that would last us, and we concluded that actually we'd probably run out of money by the time we actually got our first NHS hospital to work with us. And anybody that works with NHS hospitals knows, it takes a long time to get your first one, but even after you've got your first one, they're often asking, who else is using it before they decide to commit. So we decided to focus on primary care first, where the clients are much smaller, where you do not have to go via frameworks to sell to them, and a lot of them are really innovative. Like, a lot of them are they're business people, so happy to try something new, and particularly if it's something that solves a pain of theirs. So that's what we did. So we started out in primary care in Tower Hamlets, working with Tower Hamlets CCG, and we started signing up lots of GP practices in Tower Hamlets first of all, and then ended up doing our first kind of collaborative staff bank, which was the first collaborative staff bank in the NHS back in like 2013, and we did that with the Tower Hamlets CCG combined. We were like, well, all the practices in Tower Hamlets bar like 4 are on Lantern, so why don't you do a group buying deal basically and combine them, and then you can actually share all of your clinicians across organizational boundaries, which would reduce the amount of money they spend on locums, but also ensure that they're always working with local clinicians. So yeah, so our we went to primary care first because we just felt it was much easier to innovate, and we wanted to get a stable base before we then went on to try and serve much larger clients. And what was your second question? I've forgotten what your second question was.
How have your investors been during this whole period and that kind of side of things?
Yeah, our investors have been pretty amazing, actually. We did an internal funding round. Like, as soon as COVID hit, we could see that the investor market was gonna be hugely different, and a lot of VCs were actually starting to look inwards at their own portfolio to support their own companies that they'd invested in, over and above going and finding new deals. So we therefore decided that we wanted to ensure we had enough runway to survive through COVID and beyond, and so really quickly basically got on the phone to all of our investors and asked them to support us in a bridging round, which has enabled us to. We've got another 2 years now that we can survive, even if we didn't grow. And so, yeah, they were amazing. Like, they could all see that we had a really important part to play. I think they all believe a lot, you know, in our mission. And I think that actually they could sort of, like, if they were kind of comparing all of their other portfolio companies, a lot of them are in industries that have been really badly hit. I think they would prefer to support the companies that they know are going to survive throughout the other side, which is a kind of, you know, it's a terrible thing to have to think about, you know, and particularly like being an entrepreneur, you know, how difficult it times can be, and how hard it is to sometimes pull yourself through. And so, you know, sadly, there are going to be a lot of companies that are not able to get the support. I think it's different for healthcare. For once, it's different for healthcare because, you know, people can see that actually it's almost counter-cyclical. So even as the economy, you know, takes a hit, I think organizations that are uniquely placed within healthcare to either reduce costs or improve patient care, or improve efficiency, you know, they will still have the ability to grow throughout. So I think there's going to be a real rebalancing of venture capital funding away from consumer and actually towards like more enterprise software or in health tech, especially I think after COVID. So yeah, so it was a very long-winded way, but they've been really supportive, and we've got some really good investors on board. So, you know, we feel very lucky for that.
That's fantastic. Ash, what are your your first NHS like partnership, and I'm not sure you've actually, and yeah, and how are you finding kind of the money side of things, the investment side of things?
Yeah, so we, you know, the main hospitals we've been working with are in and around the regions that I know. So London and Essex. I alluded to earlier on the fact that there's some really good structures in place in terms of innovators, NHS trusts who are geared up to take on innovations such as ours. You then build your relationships with them. And then once you're embedded, you're able to bring in different types of technology and solutions and test different things out. And it becomes, like, you know, a really interesting starting point for new products you may or may not push out. You know, for example, one of the trusts in Essex recommended us to the HSN. The HSN took us to Royal Papworth, and in a month or two, we're going to be trialing a new product where patients can report problems they see using MediShout. So if you go into the toilet and there's, you know, a lack of toilet paper or something's blocked, or, you know, there's car parking issues, the MediShout app will be there for you to report things to the state. So I think it's really key. I guess it's kind of the opposite story to Melissa. I've gone through the pain of starting with hospitals, but again, for me, I'm a hospital surgeon by trade. That's where I saw the problem. So that's the problem I wanted to solve first and foremost. And now we're sort of maybe going in the opposite direction of looking, how can we help primary care and social care? In terms of investment, we, again, a little bit of luck. It just happened to be that in February, we closed a sort of pre-seed seed round of funding, which has definitely meant I've slept just slightly better than I might have done otherwise over the last 2 months. But actually, again, because we're suddenly realizing that we can help healthcare massively, not just in the UK, but also abroad, we're currently doing another funding round at the moment. We've been quite lucky that we've been talking to some investors anyway, and they actually approached us and have said, actually, Ash, we can see the need for your product more than ever. And so, you know, we were really lucky that they've sort of come to us. So we've got over half the amount of funding we're looking for promised. And in this time, you know, with funds dried up, that for us is amazing. Speaking to lots of colleagues in this sort of startup space, you know, it's difficult at the moment. Funds are either putting money back into their existing companies who they've invested in to keep them going, or they're just looking to hold tight, or some funds have had their funding from bigger funds sort of frozen. So it's really, really difficult. And, you know, I empathize with a lot of, well, startups are going through, but hopefully everyone can just go into survival mode and just get through this initial period, because I think there's going to be, there is a massive need for innovation in health. There's always been a massive need, but now even more than before, because we've got a huge backlog of cases and coronavirus is not going to go away anytime soon. So anyone that can help, you know, surely will do well in the long term.
Brilliant, thanks. So I'm just kind of conscious of time, and we've still got quite a few more questions to go through, including on from YouTube. So I'm going to ask Richard a different question now. The question is about, clearly you're in a leadership position, and part of the COVID experience has been working with your staff in completely different ways, with everyone, I'm assuming, like working from home. What changes do you think you're going to make to your workplace and or working patterns as an organisation, as and when people could actually return to the office?
Okay, so I mean, we were in just a very fortunate position as our workforce was 95% remote pre-COVID. So Healios is a virtual company by nature. We just have a small office that's focused primarily on back office operations. So yeah, 95% of the workforce was remote anyway. And going forward, that will still be very much the same for us. We'll still be a virtual company primarily, and we'll still be expanding our workforce, and those will all be remote workers. So yeah, just very fortunate position that COVID has had no impact on our actual structure as a company. But what's been important though, while we're a virtual company and we've got lots of expertise of delivering all of our work virtually, that just the home situation, of course, of our staff has changed. And that's the bit that we've been paying more attention to, which is to ensure that while our staff have been used to working from home and so on for Healios, that we're also very cognizant of how they may have now different stresses on their life that are coming in through of course, lockdown and now moving out of lockdown. So that's the bit that we've been focusing more on. And of course, we'll be continuing that as going forward, and maintaining our staff well-being is our number one priority anyway.
Thanks, Richard. That's really I mean, it's really great that you already set up in that way. I'm actually going to ask Melissa, who I know previously had quite a large office, a relatively large office in central London, whether you think that you will be going back to that large office, and or if there are things from this experience around with everyone working virtually that you want to keep going forward.
Yeah, it's actually something that I was talking about today. So, I mean, yeah, we have a massive office. It probably fits about 150 people, maybe more. We are 68 people at Lantham, so we don't nearly fill it all. And we had always subsidized the cost of it by subletting it to other companies. And it's really interesting because we talk a lot about like how COVID has changed, the like different parts of the market, and like how it changes healthcare and how it changes our market, but it's also changed, the office space market. And I don't think it's going to be as easy to get people to sublease our extra desk space that will help us contribute to our rent. So we now need to think about, okay, well, what do we really want to do? Because we've really surprised ourselves with how quickly and easily everybody's adapted to working remotely. A lot of our team actually prefer working remotely. So quite a lot of the tech and product team, like they actually really like working remotely. Sometimes they just need to be like head down, no distractions. And if anyone has ever met people from my team, they can be quite loud. And so now we're starting to think about, okay, well, maybe we have a different operating model where we don't necessarily need a massive office space, and maybe we could have a smaller office and we do hot desking, for example. I think particularly as we expand into the US as well, there's more people from the team going over there, and I've been in the office a lot less, just like before COVID, being in the US. So we are starting to think about actually, like, does it make sense to review our operating model and how we all interact with each other? So yes, it's a really good question, and definitely something that's on the table for reducing, because obviously it's also a big cost. And if we could free up that cash and use that to invest in more product build, then I'd be all for that too.
Brilliant. That's I mean, it's probably something that every kind of company is working through now. Chris, so this question's for you, and then somewhat inspired by the wallpaper behind you. So clearly you are a parent and a leader. How have you found like managing like that aspect of this? And like the actual question was, how is everyone coping? But that's going to be like my interpretation of it.
The wallpaper is a coping mechanism. Surround yourself with. So I've actually had a third son 2 weeks ago, which is a strange time to have another child join the family. I guess it's really nice being at home more, like and similar to the guys that just spoke. We had a lot of remote working stuff anyway, but I was spending time on the train for an hour and a half each way to London most days of the week, which clearly is not happening now, and I'm probably way less tired because of that, so it's really nice. We've got kind of family stuff that probably wouldn't have happened otherwise, so like I'm doing Joe Wick's workouts with the boys, which is really fun. It just wouldn't have happened, like wouldn't have been home in time otherwise. So it's been actually, in a funny way, I think I'm more productive like this, and I think a lot of my team members are saying similar things, like they're, as Melissa said, adapting really well to remote working, but actually having more kind of work-life balance, which has been really nice.
Oh, I'm super jealous of that one. Like, I feel like my work-life balance has deteriorated massively in the last month. But you know, one lives in hope. Cool. So, Eleanor, this one is for you. So. And it's kind of like, hopefully you'll say a good thing, but please just be honest. So it says, a number of startups have found interacting with the NHS quite tricky, and it seems that NHSX are only interested in interacting with big tech. How has your experience been?
Good question. I'm not sure I'm the ultimate expert. We should probably crowdsource some opinions on that front. I would say it's challenging. I can see a massive difference pre and post COVID, or rather pre and during COVID, in terms of just the openness to various NHS stakeholders to work with smaller companies. I mean, I mentioned TechForce 19. That's an NHSX program. That's kind of a testament of the fact that they are open to kind of innovation that's earlier stage. There might be a little bit more kind of cutting edge or experimental, if you wish, but in some ways better positioned to tackle kind of the emergency. What that looks like moving forward, I hope that's something that stays. I hope that's something that opens more doors, and it's not the kind of older model of kind of, it takes about 6 to 12 months to actually get through an NHS stakeholder, but who knows. I think for that specific reason, we personally have focused on social care, as well as kind of private providers of social care, just to accelerate access. It's probably something that Melissa was saying in terms of GPs as well, just finding that kind of smoother entry point before you tackle the kind of more sizable, chunky organizations.
Brilliant. Thank you. And that is slightly encouraging. Richard, I know you have had the pleasure / pain of having to deal with NHSX as well. Is there anything that you would kind of want to add into how that experience has been? And I guess, you know, as an employee, I'm really happy to take feedback back into the organization of how we can make working with us better.
So actually our experience with NHSX is quite recent, as most of our experience has just been directly with NHS mental health trusts around the country and CCGs. So we've been quite fortunate that we're commissioned by 50% of NHS mental health trusts and quite a sizable number of CCGs directly. So we've been very fortunate in how we've managed to work in a really kind of co-design, collaborative way with NHS organisations to support them in designing new models of care going forward, and that's been, you know, such a great partnership kind of relationship with really forward-thinking teams in NHS organisations around the country. So, when we started off, it's always a painful journey. We've been quite lucky to bring some service solutions that really kind of helped NHS Trust move forward. And so with NHSX, it has been a little bit new as we took Think Ninja to them to get their support, and it has been a very positive interaction. We've worked with a number of colleagues there at NHSX. They've been responsive to and very supportive, actually, with moving Think Ninja through those internal processes with the digital assessment questionnaire as an example. So it's been a positive experience. We haven't got to the end of it yet, so we're hoping that end is in sight pretty soon. We've been told sort of any day now that we'll be through NHSX and have their full backing on Think Ninja, but we'll just wait with bated breath on that.
Brilliant. Well, that is encouraging. So final question, quick fire, one word, fun one. What has been your one kind of COVID discovery? And I'll kick off. So my mad pre-COVID purchase was a little trampoline, and that has definitely kept me sane during this. So trampolining is my one word thing. Melissa, do you want to go first?
Oh God. Okay. Yeah. I mean, I've been doing, and this is not one word, but yeah, I've been doing lots of home workouts, but with my friends via Zoom. So we would like project the home workout and then all do it together. So it's sort of like socializing, socializing whilst getting fit.
Okay. Social workouts for Melissa. Chris.
Mine's workout too, but it's family workout. So 2-year-old and 4-year-old doing a workout with me, which I'd never done before this, and it's really fun.
Brilliant. Okay. Ash?
So my granddad gave my mum a guitar for her birthday 50 years ago, and I've decided to take that up at this time. I've been annoying my wife by trying to play Hans Zimmer. Not doing great at the moment, but we're only a week and a half in. One other thing, someone asked a question before about what's been the go-to app. So I downloaded the IMDb app, and given that we're all watching a lot of TV, I think you should screen what you watch on IMDb before you commit to 2 hours or a long series of your time.
Brilliant. Okay, Eleanor, is yours also exercise themed?
No, I'm going to break the trend. I think for me, it's probably team quizzes and games. We've introduced Social Wednesday, where different team members host and come up with various entertainment schedules for an hour. So games and performances. So that's definitely keeping me sane.
Well done. And Richard, and then I'm going to come to you, Lisa, so think about yours.
And mine's building on Alina's there. Actually, it's doing some weekly family quizzes, getting the families together around the country and taking on each household. So that's what's been keeping us sane each week.
Brilliant. Lisa?
I've been trying to learn to knit. Lots of my friends are having babies, so I want to make them all baby blankets, but I'm truly, truly terrible. So I'm not sure how long that'll last.
Brilliant. Okay, well, thank you everyone for participating, and thank you for our attendees who've asked some really great questions. I have taken a lot from this. I thought there's some really good themes. Lisa and I might be writing a kind of blog on reflections of this if we can get our act together in the next week, so we may kind of try and encapsulate some of this, but thank you very much. I know this is probably a bit untraditional, but normally we would give applause to our panelists. So I'm going to ask that we close this out by a small round of applause. So everyone comes off mute, and then we can at least. Am I just going to clap? Come on, gonna clap. Well done. And thank you very much. And we hope to see you at a One HealthTech event in the future.
Thank you very much.
Thank you.
Thank you so much for
Thank you.
organising.
Thanks, guys. Appreciate it.